I read constantly for some reason. And I disagree with this article. It's AI robots help nurses beat burnout and transform hospital care in Taiwan. They're coming to everywhere. You got any nurses that want to identify themselves? I'm just kidding. I love nurses. You're the only one in the class?
No, we got another one. Don't lie.
Okay, so I will tell you that I worked in spinal cord injury on the ward, and I did several things, and one of them was whenever a nurse would send me something, unless I was absolutely just doing something else, I would do it right then. But one of the things I would do is, like, I would go at the end of the day, they'll have their shift meeting where we were at 4, and I would always walk over there before I left for the day, because it was a VA, and I'm leaving at 4, and I would ask, is there anything that I can do before I leave? Because what if providers do? They'll put in a crazy order and then leave, And really, it did twofold. One, it made them think I cared a lot, which I did. I got along with them great. And two, it prevented them from calling me later, because I don't want to talk to them later. And I'll tell you this: you will know what your standing is with nurses by the medication refill calls that you get. Is what I figured out. Because the residents would talk about these nurses calling them all the time, and I'm like, they don't ever call me. And this may sound negative, but we had people who were on narcotics for spinal cord injury pain, neuropathic pain, and they were on them for years and years and years. They've had the same script for years and years and years, and it would fall off sometimes like 6 in the morning when I'm not getting there till 7. And they would, for me, they would just go ahead and give the patient, as soon as I rolled in, they'd say, hey, you got an order you got to sign. Is that ethically, legally? I don't know. But those are examples. They never called me, but they would call residents. You kicked them off, and they're calling at like 3 in the morning going, hey, patient's Tylenol fell off. Passive aggressive. Right? I said all that because I think nurses do get burned out, but I don't like this article, the way they wrote it. It says, global healthcare shortage, 4.5 million nurses by 2030. Burnout identified as a leading cause in the deficit. Up to that point, I was like, yeah, because in spinal cord, you're lifting patients, you're washing them, you're doing wound care, plus all your other duties. But then they said, whatever, they got robots in the hospital. Neurovot, I'm going to summarize, collectively is designed to take on some of the most physically demanding and repetitive tasks in clinical care for nurses. This is where it went wrong with me. These include, physically demanding, these include delivering medications, transporting samples, patrolling wards, and guiding visitors through hospital corridors. Then by reducing these, it will lead to less burnout. Those aren't the most physically demanding. I don't know I bring my phone here, but I didn't know if I would remember that small bit this morning. I'll tell you what's physically demanding. We can go back to the hospital administrators on that. Physically demanding is the fact that most places you see nursing to patient ratios are way too high. That's it. They would hire more nurses. And they say, well, there's a shortage. Well, there's a shortage because you're screwing the ones you have. Anyway. But y'all know I understand. Anatomy and Physiology 1. Spinal cord injury. Spinal cord is a great thing. When you look at the spinal cord anatomy, though, before we get to the pathways, we're going to learn all the little parts and see how they tie together to deliver signals where they need to go. We're not going to spend a whole lot of time talking about spinal cord injury like I like. I'll bring in some aspects of it, but that's not what we're here to learn spinal cord anatomy. Right? But I'll tell you some things to make it interesting. One of the first things, if you look at the spinal cord, it goes inside of the vertebrae. I know to some that seems very obvious, but you have a vertebral column. We'll really define the bony structure of the vertebral column when we do musculoskeletal head, neck, and torso. So we're really just going to kind of look at the spinal cord that's going down the middle of it in this plot. So the spinal cord starts at the magnum foramen. So the brainstem ends, or the medulla oblongata ends there, and now it becomes the spinal cord. And the spinal cord continues all the way down, not exact here on my placement, but to L2. At L2, your spinal cord proper stops, and it forms an area. It's like a tapered area called the conus medullaris. So that's what we see here, where at L2, it's going to stop. I'm going to try not to get ahead of my slides today and talk over them. I talked ahead of them a lot of times. As you look at all the things that go into the spinal cord, it's like any other electrical system in my mind, is as the spinal cord ascends up the spinal column, it's going to get larger. And in general sense, as you're at the lumbar area, there's an enlarged area of the spinal cord that's kind of bulged out, and that's called the lumbar enlargement. And that's because all of the fibers from the lower extremities are entering the spinal cord at that level. And then it's still, it's thicker going up, but then it's going to get even thicker when it gets to the cervical region. Because there's a cervical enlargement where your upper extremity fibers come in and out. Right? So if you looked at the spinal cord and you were just drawing it, you would draw it from the cervical region, it kind of bulges out, then it goes through the thoracic, then it gets to the lumbar and kind of bulges out again. No, it's not bulging out like that big, but it's larger. And that's called the cervical and lumbar enlargement. Just how the extremities, fibers get in and out. So if the other thing on this slide is that the spinal cord ends at L2, and there are coverings. We talked about meninges that cover the cerebrum, and we're going to talk about those same meninges that are continuous that cover the spinal cord. But the pia mater that surrounds the spinal cord, at L2, there's an extension of it that goes kind of straight down all the way to the coccyx. And that whole structure there is called the filum terminale. And I always picture that like a belay. It's like holding on to it, right? Not really, but it is an extension that goes down and kind of, you could think of it as tacking down or keeping that spinal cord taut. It's not really keeping it taut, but it's a visual of what it is. If you're going to, now that, I never thought of this before. That makes a good thought process if you're first learning this, that you get confused, like conus medullaris and filum terminale. Because I just realized, I never thought of it. Filum terminale sounds like the end of the spinal cord to me. Conus medullaris. So when you look at the spinal cord, if it's going to end at L2, but the spinal column does not. And our spinal column goes all the way down to the sacrum and coccyx. And so if we go up here and say, that's L2. If the spinal cord ends here, but there are still nerves inside of the column, right? That's actually where we call the cauda equina. Y'all heard of that? So the cauda equina has spinal nerves in it. And I said that specifically, spinal nerves. Because we're going to define the difference between central nervous system and peripheral nervous system. And the definition is, once a fiber is outside of the spinal cord, it's peripheral nervous system. So if you look at these spinal nerves that are coming out, once it leaves, it's still in this is the spinal column, but once it leaves as a spinal nerve, now that's peripheral nervous system. Well, by definition, then, if the conus medullaris, the spinal cord ends here, there are still extensions of spinal nerves that go down through the inside of the column itself. So we gave it a special name called the cauda equina, horse's tail. If you ever watched the show Lost, that's what Jack, he nicked the dural sac and they spilled out like spaghetti on it, all the nerves. Can't even imagine the stress of that. Glad it was him, not me. All right. If you never watched Lost, that's a good retro show to go back and watch. It's pretty good. Not this year. But don't read about it on the internet before you do it, or the whole show is ruined. I don't watch any series that doesn't have all the episodes already. So I won't wait a week to get anymore. Y'all with me? Like if it's like new episode every week, I'm like, all right, call me next year. I need at least a whole season before I'm going to start. I'm going to watch those all in a row. So, all right, meninges. Meninges are consistent with what we saw in the cerebrum, in that we have the dura mater, we have the arachnoid mater, and the pia mater. So the green here is our dura mater, and then you'll have the arachnoid mater, and then lining the spinal cord itself, kind of this, I don't know what color it is, reddish, pinkish color, all of this, just surrounding this cord itself is the actual pia mater. We want to look at, because it becomes important in what's in between these layers. So if we look at the dura mater, it forms a sac that goes all the way, well, it comes out of the cerebrum, and then it goes all the way down and around the spinal cord, to include the cauda equina. It's going to run all the way down to the end, down to the sacrum coccyx area, and it circles around that spinal cord and the cauda equina. That's why when I mentioned it, he nicked that, what's called the dural sac, is the part of the dura mater after the spinal cord ends. That's called the dural sac, and it houses the cauda equina. We're going to look at spaces. So there is an epidural space. The epidural space is between the dura mater and the wall of the vertebral canal. You have to keep picturing. I keep going back to the skeleton. You can come to this skeleton and look. It actually has an amputation, but if you, let's use this one. He's all studying biochem right now, so why that's hanging on him. It was on his head the other day. I noticed. These are representing spinal nerves. Well, your spinal cord, all the green that's inside, and so between where you can see the green and the bony structures, right? Because each vertebrae, I know y'all understand a lot of this, but I'm missing some vertebrae. Each vertebrae has an opening in it. That's your vertebral canal. So your spinal cord is going through that. Now I know everybody immediately went, yeah, that's a thoracic vertebrae. I know. That's sarcasm, y'all. We'll get to that later. But the spinal cord is going up through there. So between my finger and the actual bony structure of the wall is the epidural space. So if you've ever heard giving somebody an epidural, you're putting that into that area. So that's the epidural space, and it just contains fat and connective tissue. Okay. When we look at the arachnoid mater, it's deep to the dura mater. And that means it's below the dura mater, so it's a subdural space. So on this picture, you would see the subdural space. And you gotta, this is a study picture too, but you gotta kind of pay attention because you notice the arrows go across and then go down. And when they're doing that here, they're representing that it's a space there between those two tissue layers. Y'all see that? That's the subdural space between the dura mater and the arachnoid mater. So it's subdural, and it's going to contain interstitial fluid. And then you have the space between the arachnoid mater and the pia mater that lines the spinal cord, and that's called the subarachnoid space. And this is where we find cerebrospinal fluid. Remember, cerebrospinal fluid is going to be made up in the cerebrum and the ventricles. It's going to travel down through those ventricles. It's going to go through the middle of the spinal cord, the central canal, and then it's going to come down to the bottom of the spinal cord area, and it will fill into the subarachnoid space and come back up and around in that. It flows in the subarachnoid space. So if you've ever done like lumbar taps, spinal taps, that kind of stuff, or you've seen people doing them, right, and they're feeling for what tissue layer they're going through, they're going through these layers to get to the subarachnoid space. If they're going for CSF, if you're doing epidural, you're looking for the epidural space. It's an art to learn to do that. So overall anatomy, if we look at, the butterfly pattern here, H, nowadays I think of underarm, but it has gray matter that we find in here. All of that's your neuron cell bodies. Then you have all these white matter areas that are basically a bunch of tracks that move information up and down the spinal cord. And connecting the gray matter, you have an area called the gray commissure. We have gray and white commissures, or gray and white connections. Remember, things are going to cross over. Remember the medulla oblongata had that area where things would decussate? Well, things decussate at every level of the spinal cord. Anywhere something's coming into the spinal cord, it often will go up to higher centers and go across and go up to higher centers. Right? It decussates, or if you just want to think of it more basic, you say, well, the right side of the brain generally controls the left side of the body. Well, if it's going to do that, it's going to have to cross over to the other side at some point. It does that using these commissures. Okay, so I left these. I have 4 or 5 slides on spinal cord anatomy. I could have put, they're very basic, but I could have put them all on one. But it allows me to talk some about them more and visualize what we're seeing. So, but you can combine these all in one picture if you want. You'll probably understand it by the end of the day. So these are the anterior horns. You need to pay attention to where things are coming out. In other words, what neuron cell bodies are actually there. Because it's divided up pretty, I don't want to say simply, but these are the anterior horns. Anterior horns contain somatic motor neurons. So all of the motor neurons that go to your skeletal muscles to move you around are in the cell bodies there in this area of the spinal cord. That's all they are. So the anterior horns only associated with somatic. You would say somatic motor neuron cell bodies are there. If we look at the posterior horns back here, they're going to contain all of the autonomic and somatic sensory neurons. There is a difference that we haven't got into yet, but we can generalize it and say, well, if my muscle is moving, does my brain need to know, like, how much tension's on a tendon? How much stretch is on a muscle? It does. And so the muscle actually, we'll see, sends information back to the central nervous system to say, one, is the action you're doing what's happening, or do you need to send a motor signal back down to cause it to relax because the tendon has too much pressure on it. So all of that occurs. So there are sensory things, we'll just call them things for now, we'll get to that, in there that tell the brain what degree of stretch or tension's on a muscle or tendon. That is a somatic sensory. It's sensory coming from the somatic motor, like skeletal muscles. There is also an autonomic nervous system. So your bowels are constantly moving and stretching, and it needs to know what's going on. So it sends sensory fibers back to the central nervous system that says, hey, you need to adjust something, or this is what's going on. That's autonomic sensory. So all of the autonomic sensory neurons and somatic sensory neurons are found in the posterior horns. So somatic motor neurons, anterior horn. Somatic motor and autonomic motor neurons are found in the posterior, autonomic and somatic sensory neurons are found in the posterior gray horns. Another way to think of it is all sensory coming into the spinal cord comes into the posterior horns. All motor that's leaving goes out of the anterior horn. The way it's divided up. So what did we leave out? Actually, I should have had it as the next slide, but I don't. But what did we leave out? What neurons do we still need to look for? Autonomic motor neurons. I'll show you where those are in just a second. The central canal, because they're not depicted exactly here. The central canal, we already know that's where cerebrospinal fluid goes down and through. Golly. We have a gray commissure, and just in front and behind that, we have posterior and anterior gray or white commissure. So just connections. You don't have to focus as much on those. It's just how things cross. Now, if you notice this picture, if you look at this area here and this picture, they look a little different, right? See those popping up, little horns? Those are lateral gray horns. All autonomic motor neurons are in the lateral gray horns. Never going to get my throat clear. So this is where it starts to get, up to now you're just anatomy. Now we start to get a little more into it and say, well, what these lateral gray horns are only found, the reason I showed you the difference between those two pictures is the only place that you have lateral gray horns are in the thoracic and lumbar, T1 to L2, T1 to L3 region, normally T1 to L2, and the S2 to S4 segments of the spinal cord. So these are autonomic motor neurons, and we only find autonomic motor neurons leaving the spinal cord at T1 to L2 or S2 to S4. So those are the only areas that we need to have lateral gray horns. That'll make a whole lot more sense when we talk about, remember when I showed you all the difference between what sympathetic and parasympathetic systems are, why it's called parasympathetic? That's because, and I don't want to get too far ahead, that's because when you look at the output, motor output for the autonomic motor nervous system, T1 to L2, all of that is sympathetic output. So in all of that area, we have sympathetic autonomic motor neurons that need to leave the spinal cord. And then it said, well, we also have lateral gray horns down here at S2 to, just being general, S2 to S4. That's because the cranial nerves and S2 to S4 are the areas where the parasympathetic fibers come out. So you're going to need a couple of lateral gray horns down here. You don't need lateral gray horns up here because it's brainstem for spinal or for cranial nerves. That's the parasympathetic system. Am I getting too much too soon? It is for me. I'm glad I know this already. I'd be having a tough morning. Just hold on to that info. I promise you it'll tie back together with when we look at these systems jointly. Yeah, now I understand why you only have a lateral gray horn.
Sir, how about the spinal cord ended at L2? So how do they have gray horns in the spinal cord?
I was hoping nobody would answer that. I'm kidding. It's a good question. It's because I cut the difference. The spinal cord could end at L2 to L3. Most books will reference L2. And so a lot of times when I simplify, I don't get it on the other side of that. But you can think of it as L2.
No, sorry, the S2 and S4.
Although, I'll get to that. No, I'll answer it. I thought, I can't leave it hanging like that. Because the spinal cord ends at L2, but the sacral output of the spinal cord, where it comes off of the cord itself out, is there. The spinal nerves that come out for the sacral region come off the spinal cord L2 and go down. In other words, you have very long spinal nerves in the caudal plane. Tracking that? See what I mean? It's at that level. It just, I don't have a diagram here, but if we looked at where autonomic output for the sacral region came from, S2 to S4, it actually came off of the spinal cord up here at L2. L2. But since the spinal cord ended, that fiber came out, but it stayed in the vertebral column until it got to S2 or S4 and came out. S2 to S4. So they're looking at where it comes out of here. So there's an offset. We're going to discuss that, but it's an offset caused by the fact. Actually, let me leave it there for just a second, and then I'll show you how they got there. But that was a great question. I was just kidding about it. I was wondering if anybody's going to ask. But I did when I saw that L2, L3 on that slide. I thought somebody's going to ask me that. And so there's a busy picture of the spinal cord. And I've spent a lot of time with other people and mapping out and learning all these tracks. And I told you, we're not really going to learn every track and label them. I don't know how much that is valuable for us. But we do need to recognize that these anterior and posterior gray horns, all of the H there, actually helps to divide up the spinal cord into where we're going to have some anterior white columns out here, we'll have some posterior white columns back here, some lateral white columns. And all that's saying is that there are myelinated fiber tracts, white matter tracts, that we could define out on each area of the spinal cord. And so they're all going to have, if we map out an area of the white matter in the spinal cord, we can actually map where it's going from and where it's going to include what it's doing. And they name all those tracks like you see here on the screen. But we are not going to label this. And forever, you'll know what a tract is if you know how to use it. I said this yesterday, I think. Let's just pick out one like lateral corticospinal tract. Well, I'm betting that's lateral. So it's probably in a lateral column. Corticospinal. Cortex, the spine, is that descending? Yes. So we know that is a motor tract. And so if we pick out another and say, well, I know I did this yesterday. Trying to find one that you might not. Rubrospinal, we use that one, right? Rubrospinal, red nucleus to the spine. Once again, a descending tract. Spinothalamic tract would be an ascending tract. Now, I know it's color-coded and you got a key there. This is how you pick them up. You hear it, figure out where it's going to and from, and you know whether it's sensory or motor. I don't care if you can tell me exactly where it's at by labeling it. Because you'll never think of that again. Literally. You'll hear these tract names, but you're going to learn a lot about like the spinothalamic tract and how it develops in children to adults and all this. And now you'll know what it is. You may never be able to label it. Okay, so bundles of myelinated axons have a common origin, a common destination, and are all carrying similar information, then they would name them for that tract. So once again, sensory versus motor descending. Each of the posterior root, we haven't defined root yet, but we're going to start, there is autonomic, somatic, autonomic, and then sensory. So all of those exist in there. When sensory is coming into the spinal cord, it's going to come in using what's called the dorsal root. This is the dorsal or posterior root. Well, just before it gets there, we can always tell in a picture which side of the spinal cord we're looking at by looking for the dorsal root ganglion. Do we remember what a ganglion is? I know that was so last test. A ganglion is a collection of neuronal cell bodies in the peripheral nervous system. So anywhere you see a clump of neuron cell bodies in the peripheral nervous system, it's called a ganglion. So we have this dorsal root ganglion, which contains most of these sensory neurons that are coming in. Like the neuron that's out here picking up touch in your finger is going to have its cell body in the dorsal root ganglion. And when you identify that, we know that side's sensory, whatever picture you're looking at. The anterior and ventral root is where motor goes out. I'm not going to define out a bunch of what we call rootlets, but as things need to get to where they're going, so as all these fibers coming on the sensory side, right before it gets to the spinal, it does it at the worst time. When it gets to the spinal cord, right before it gets into the spinal cord proper, it's going to split into a bunch of different branch kind of things called rootlets. We could go through and map and name rootlets, but we're not going to. Same thing happens when it comes out of the spinal cord. You're just condensing. It's like wrapping the Velcro ties around all your computer cables, right? The more that come together, we get them into one bundle, continue them on it. So I threw this in here to kind of tie up and finish off what we're talking about. The spinal cord tracts and how they process information is, we know that white matter tracts can ascend or descend. And this is how it occurs in a general sense, is that if we look out here and follow these numbers, we have 1. So we have some type of sensory receptor, let's say touch, out here in the skin. That's going to send a signal along a sensory, somatic sensory in this case, neuron, and it's going to go all the way up, and its cell body will be in the dorsal root ganglion. Then those sensory fibers are going to come into spinal cord. Now I'm getting a little ahead of where we're going, but I like to show the overview. When that happens, that information needs to go to the central nervous system and on up. So it's going to travel up. But it's also going to synapse with another, what's called an interneuron, and it's going to carry that information to the other side, and it will go up that side also. And then it will come back down as a motor tract and synapse with the motor neuron to take that back out to the skeletal muscle. In that case, like you touch something hot and you're moving your hand. That's just a basic example. Autonomic system, the sensory would come in, but that autonomic sensory, if it came out of these motor areas, it would go to the autonomic system organ. So it's traveling in and out. Now what we left out and what is represented on that picture is reflexes. We'll talk about reflexes on their own, but that's the general process. The whole key here is to show how is sensory getting in, how is motor getting out. Yes?
So the sensory impulse is going up the same side and the opposite side that it's receiving.
What was the last part?
If the impulse is received on the right side, it's going up the right side as well as the left.
Yeah. And I'm going to get a little bit ahead again as I do. Is we're going to talk about things like, what if you're walking, you're running my talk later, but I'll say it again later, then, because I'll forget that I told you. Now, what if we're walking and we step on a tack? My left foot steps on a tack. There's what's called a flexor withdrawal to pain. And so if I step on a tack, what am I immediately going to do? Pull my foot up. Okay, well that makes sense because the sensory over there picked it up. And if it just, forget about decussating for a second. All of this involves decussating to cross over. But I want to say this example. If I step on a tack, I get a flexor withdrawal. And then on the other side, I'm going to have an extensor reaction. And if you watch somebody step on a tack, you would actually see them. As this foot comes up, the arm comes out. It's a balancing thing. And your other lower extremity, in other words, both sides have to know, because if I lift this foot off the ground, what is this? If I flex away from pain, what is my left leg? What does my right leg have to do? It has to extend or I'll fall over. That's why it's. I can give another example would be hearing. Is if I'm sitting here and I'm hearing out of both my ears, right, and I hear a sound over here, one shot, one kill, right? Turn your head towards that sound. Well, the ears can actually time. So when the sound reaches this ear and it goes in, and this ear, so we hear a sound out there and it comes in, it actually goes to both sides of the brain. The information does. And the brain can time, like let's just picture if it came in the right ear, and some of those fibers are going to go in and go up, some are going to go across and go up. Well, it takes slightly longer to go across and go up, right? And we're talking very fast. They're slower, so it goes to this, hits this side first, then it hits the other side as it goes up. Because of that, the brain can tell where that came from, what sound. It's a slight difference in timing. I got a little windy on that explanation. We were going to say all that eventually, but it started to get me worked up. I find that interesting. I like those things. Right. What is a spinal nerve? Spinal nerve is what's going to connect the spinal cord to muscle glands, whatever, viscera, whatever it might be. This skeleton has a representation of spinal nerves. I'm calling it a representation because there are different names for where we're at, where it's coming out. But for now, just picture that this skeleton has 31 pairs, one on each side of spinal nerves. And you can visualize them with that green. And I'm going to define out exactly the area that's called the spinal nerve and tell you why, but we'll get to that in a second. So there are two bundles of axons that connect to each segment of the spinal cord. So if you go to T4, you'll have a spinal nerve on each side. A spinal nerve contains sensory and motor at that point. I'll show you what I mean here in a second. Then you have the rootlets. We're not going to do that. So you have a posterior root, as we discussed, and you have an anterior or ventral root. Posterior dorsal is always sensory. Anterior is always motor, whether that's somatic or autonomic. So once you have a spinal nerve come off of their spinal cord, immediately that's where the peripheral nervous system starts. Anything outside of the spinal cord and cerebrum is peripheral nervous system. So they're just the way we're going to connect the PNS and CNS together. We've got 31 pairs of them. If you've learned this before, one of the things we don't talk about a whole lot is kind of odd, that spinal nerves are generally numbered according to the level of the vertebral column as they emerge. This is going back to your question earlier. Is generally, when we look at these, they're going to come out on each side, and so you would see these spinal nerves. At each level they emerge. So the first cervical pair of spinal nerves actually emerges between the occiput and C1 vertebrae. They're coming out of each side. All others will come out between two vertebrae. You got to get this point because if you look at the atlas up here, if we find this, here's the magnum foramen. This set of spinal nerves that we see here is coming out between the occiput and C1, the atlas. It's coming out just above the atlas. All the others will come out between two vertebrae. Okay, so each one of these, so if you look at T4, T5, there's going to be a spinal nerve coming out on each side. There's a reason why I'm getting so deep in trying to explain this. There are, when you look at vertebrae, bones, 7, 12, 5, 5, 4. And when we look at the bones, there are only 7 cervical bony vertebrae. But there are 8 cervical spinal nerves. And that's the whole reason I'm trying to show you this one up here, is because it comes out above, and generally they come out below, everywhere except everywhere in the spinal column except the cervical region, spinal nerves generally come out below their named vertebrae. I'm going to show you, I'm going to get on the screen and show you more. So if we came up here and numbered them, we would see that we have C1 coming out here, and then we get down to, I mean, it's so small. If you look at, if we counted these and said, well, this is 1, 2, 3, 4, 5, 6, 7. And then we came back and we see that there's 8 cervical. And we see there's 8 cervical spinal nerves. When you get down here to C8, it's coming out below C7. But if you look at every other area, look down, let's go down to T5. If we keep counting and we said 1, 2, 3, 4. If you look, after you leave the cervical region, all the spinal nerves come out below their named vertebrae. All that to say, you can just remember there's 8 cervical spinal nerves. Whether you actually understand that or not, that's fine. But that's just a fact about it. And then we have 12, so we have 8 pairs of cervical, 12 thoracic spinal nerves, 5 of our lumbar, 5 sacral, and then 1 pair of coccygeal spinal nerves. I explained all that really for a lot of people who study this form, and in their minds they go, well, if not, people will start asking later, why are there, you said there's 8 cervical spinal nerves, there's only 7 cervical vertebrae. That's why. If you've studied these before, we don't often talk about that. Unless you're working in spinal cord again. Okay, you asked me a question earlier. That's part of it, and here's the other part. This answers your question. Sorry, I don't know the answer very well. I'm not Holzberg. Is that? She had y'all put these in, right?
We swapped the ring.
And I don't know if we're really on. What? Y'all swapped? That's good. That'd be funny. But I don't know if I'm on first name basis with any of y'all yet. I don't know. That implies like you like somebody. You start using the first name. I'm kidding. I'm actually kidding. Spinal cord ends where? L2. But where does the 5th lumbar spinal nerve come out of? Well, we just defined it. It comes out at L5, right? So if the spinal cord ends at conus medullaris here, it ends right at that level of L2. But we know that spinal nerves are named for the vertebrae they come out of, and L5 comes out here. In the picture, I should use what I'm using in the picture. And here's the thing. L1 leaves the spinal cord at T11. L1 spinal nerve actually leaves at T11, but it leaves the vertebral column at L1. Now that doesn't occur. You see up here it doesn't occur much. There is an offset as to develop. The reason for that offset is your spinal column is growing. But as a child, did I give an age on there? Yeah, I probably didn't. When you're young, your spinal cord, you're 4 or 5 years old. When you're 4 or 5 years old, your spinal cord stops growing, but the person doesn't. So let's just say at 5 years old, your spinal cord is as long as it's ever going to be. But your vertebral column is going to continue to grow. So if you looked at a child that, let's say, 3 or 4 years old, all of these spinal nerves would come straight out at the level they are. You wouldn't see this offset. But the offset's because the column kept growing and the spinal nerves had to get a little longer. Does that make sense? Yes, no, maybe? That's why. That explains your answer earlier of how we get to having that down there. It's the definition of, did it come off of the spinal cord, or are we talking where it came out of the spinal column? Fair enough. But when you talk about your question with autonomic nervous system, you say, well, S2 to S4 provides parasympathetic output. Well, it does. It provides it, if we follow S2, it's part of the cauda equina, and this is autonomic parasympathetic output, but it actually came off all the way back up here to L1. But for some reason, you're still saying the same thing. If you're just talking about the autonomic nervous system, you'd say, well, the output comes out of the spinal cord at S2. Well, that S2 is really, of the spinal cord, is really up here. But the S2 spinal nerve is just very low. Kind of makes sense? All right. That offsets, that whole next slide, that's offset is because, or how we develop our kata climate. Decent place to take a break before we get into the rest of it.
Oh. Trying to lock this before. I took a shave. That was me this time.
It's not something we don't have to. I'm not telling you that.
No, you didn't. Yeah, I did. You want to be in the
Spinal nerve grows really long. But this actually because as I have it's just that these become very long. And then it tells about spinal cord. Because it stops growing. But the extra spinal nerve, the bone, even less.
I go and I knew her workout. You're right about a lot.
New golf shirt. What's that?
New golf shirt.
Yeah. Right. Not like I don't have. Yeah.
Paint like that, so you see through.
Yeah.
Saw that.
I got bad
Good
hips.
for them hips. Huh?
Yeah. You can get all that stuff free through the Army. I got this. I got leg compression socks. I got those leg compression things you put over your feet to your knees. Turn it on and it compresses.
Oh, really?
Yeah. Get all free.
Way. I mean, like, I see my wife do all sorts of crazy free stuff when she's pregnant. Get, like, all, like, milk bags and pumps and all that stuff. What's that? What's the process?
Well, we had a clinics, so they just gave us paperwork, we filled it out, everything we wanted. Like the big seat pillows, that you can like a big pillow in your bed. It's like a big seat. Lay on it, legs can go on the side of it. Yeah. I have to figure out if they can do it here. Yeah, paperwork you fill out and you send it to them, and they send it all to your house. It's nice to put it on my feet and just turn it on while I'm like studying or something.
It's just getting there. It's like I'm in physical therapy.
Yeah.
Did you ever do anything like that in physical therapy? When they do that, like, but it's like much. I think it's more intense than you're talking about. But it's like hard squeeze.
Yeah, that's what
like,
it is.
Yeah. And it's supposed to like help stimulate muscle growth as well.
Yeah, it's painful because it'll go up to like level. It's like 2 different levels. You know, squeeze your feet, then squeeze like lower calf, and squeeze all the way up to the top. Like, ah.
Yeah,
I
remember during physical therapy after my knee dislocation, I did a lot of that for the quad to help build muscle quicker. And then while it's contracting, I'm doing my 6-way hip or something, you know? And it's supposed to like help do it under stress. And I just remember like my muscle, like the 2-pound weight on my ankle would just be on fire.
Yeah.
That's so cool. I mostly just want to get the pillow for my wife so I'm not her sleep.
Yeah.
I can just enjoy my sleep by myself.
My wife took mine.
Yeah. So how's the young one out in the pool?
Crazy. He's got to check up today to see if it moved at all. But yeah, he's crazy. He's seen him.
There's no you can't get out and like go release that energy now. Like,
Go to the zoo and stuff like that, but he can't go on a playground, can't go in the pool, can't do any kind of slide.
Tries to punch his brother with the gas.
Can't get on a trampoline.
he basically has like a hawk arm. He's
Well,
a personal hawk hand.
He tries to use it too.
Dang. I couldn't imagine trying to read someone as a 3-year-old. Like, hey, you need to chill out.
Tell him about
He'll say, no, all good. Huh?
when he hit you in the nose.
2 nights ago, he did it last night too. So he's sleeping in our bed, so he went home to fall out of his bed. And he like was sleeping and flew over and he was straight across the nose at like 2 a.m. I was like, ah.
It's a good way to wake up.
Yeah.
At 2 a.m. nose shot, I would have been like, all right, I'm on the couch. I'll see you in the morning. I'm out.
He did to my wife too. He like rolled over.
gentle parenting.
But I do understand it is in here. S3 originally 25 years.
I think it's so funny how much this is.
Yeah.
Like, wait till August.
Boots are melting the concrete.
That's normal. That's regular field. Real field is like 125. And one of my friends, she's from South Dakota, and she just had a conference in Dallas. She's like, oh my god, it was terrible. I was like, Afton, you're used to 40-degree weather.
Yeah.
Like hot for you is 65 right now. I was like, it was 97 that day. She's like, it was also so humid. I said, yeah, it's been raining a lot.
That's how El Paso was.
Dude, the last few days, like,
Sandstorms too.
I went to go run these last 2 mornings, and I was like, fuck, no.
I ain't running until the ACFT. Or what is it now?
AFT,
AFT.
fitness test.
I don't run this much anymore.
Got me wired.
I'm tired. I had to throw it in.
I got them for NTC because like
Drinking
drinking
same ones that used to come in the.
So it's an ice. No,
It's a white.
they're a little. Yeah, I don't think they're the same, but they're.
You see, they got MRE boxes for sale in the commissary. 198 orders a box.
I just whenever I went out to the field, it was those 3 hours $7 because you always had too much and soda to feed it.
I remember they used to make one omelet. Disgusting. Oh.
It was like soupy.
It was, oh. I tried it once. They discontinued it though. Yeah, they did. I remember they came out with a pizza. Everybody was like, oh, pizza. That's the Genius Caffeine.
Gonna keep me from drinking energy drinks.
They did do some.
I saw somebody tomorrow do the 5-hour energies. We don't have to pee as much. I get some new smelling salts. Not put it straight in my nose, but just like, yeah, from a distance, like when I'm studying. Yeah.
Alright, here we go, here we go. I had to go get another Dr. Pepper. Get woken up. Alright. Everybody wants high-speed graphics, but low-speed graphics generally do a job better sometimes. Alright. High speed as it comes. Has Dr. Bundrant's name on it. I guess he made this. And Cardinal Health Supply made Malaysia. That's fine. Okay. Yellow is your spinal cord. The white is your vertebral vertebrae. Or your vertebrae. And so you can't see up here completely, but right now, on this spinal cord, it says T11, and this is T11 vertebrae. So as a child, your spinal nerves look like this. So T12, L1, L1 vertebrae, they're all next to each other. Now as I start to grow, after 5 years old, my spinal cord will not get bigger. But the vertebrae will. You're going to get taller. And so when you get taller, try to do this and hold it. It's going to do this. Now, what people are having a problem understanding is that L1, if you say spinal cord, where is the dorsal and ventral root for L1? Well, it's right here. But where does the spinal nerve for L1 come out? Well, we can follow that down. Now it's coming out. It has an offset, and it comes out down here underneath the L1 vertebrae because you grew. But where people are getting confused is, well, wait, what about these sacral spinal nerves? The sacral spinal nerves, and this green should be representing. Does anybody have an idea? There you go. Filum terminalis, holding it down. So this is your cauda equina, your horse's tail, which is basically your sacral spinal nerves. The sacral spinal nerves, though, the dorsal and ventral root for a sacral spinal nerve is here. It goes in and out of the spinal cord there. But the spinal nerve is very long. So all of the cauda equina would be considered peripheral nervous system. Even though it's not going to leave the spinal column until S2. Does that clear up any? And if you want, you can spend time staring at this graphic. That's why it just grows. Mm-hmm. And then, so you didn't ask the questions though. We don't need to get into that too much. Why do we care about that? Why don't you just name them where they come out? Well, you don't, but people like me do. Me do. That's such a great grammatical example. Half the battle is recognizing that you say those things, but they're not correcting it. Why does it matter? It matters in a spinal cord patient, for sure, because if you tell me you injured your spinal, I'm going to be kind of general, you injured your spinal cord at a certain level, then I can figure out what have you lost. Right? So where's the damage? And you say, okay, well, we could figure that out without knowing all that. Well, I also need to know that because the things that we've never heard of is if you have spinal cord damage at a certain level, transected it, we can figure out what you lost below it. But most spinal cord injuries are not complete. They don't completely sever them. They get swelling and it kills off part of the spinal cord basically. But as their patients of mine for years, we often have to do dermatome exams. And let's say I'm doing a dermatome exam on a patient that's a C6, 7 injury. And I'm doing the dermatomes. And no, I need to change that and make it a better exam. They injured their spinal cord at T4. And so I'm doing the dermatomes, and they lose feeling once I get to the T4 dermatome and below on the body. I'm doing it on the body. So they lose feeling at everything below their T4 dermatome. Then they come in year after year, and every year I'm going to do an annual exam on them and figure out if they've had any changes. One of the first things I'm going to do is a very detailed kind of dermatome exam. And what if they come in and now I'm on their back side, front side, doesn't matter, and at T1 they have diminished sensation. They're like, I can't feel that. But I know they could last year. That's a problem. That's a big problem because we don't know everything about medicine until we learn it. And I didn't know this until I got there, but what happens at the level of spinal cord damage, sometimes you develop a cyst, which is called a syrinx, and it will shoot up and grow inside of that, and it will start to compress on spinal nerves higher or lower. And so you'll start to lose more fibers out of your spinal cord. That makes sense? If it doesn't, think about this. What if you've heard of C5 to stay alive? What if I'm a C5, C6 injury, and I get a syrinx that goes up to C3, C2? I quit breathing. Yeah, exactly. Hopefully that explanation helps. We're getting a little detailed on it, more than we really have to, but that's why. Sometimes you got to know the why. Make sure we're right. Okay, spinal nerves. We're not going to name the rootlets. We're just going to realize rootlets exist on the ventral and dorsal roots. They will converge. And actually what happens, this is going to be a little different, is you have the dorsal root. Remember, that's our sensory. You have the ventral root. Here's your dorsal root ganglion at every level of the spinal cord. I gotta switch to this. How did it go? These are all the same. I was working your way out. I drew it all in one. That purple, blue area there is your spinal nerve. Okay, so I'm going to give you a example of why I said earlier that these green, and you can think of it this way for here and for testing, that's fine. I'm just stating what's really happening is this is a spinal nerve representation because where you see the purple there, that's actually, anybody seen, there's like two vertebrae that there we go. Oh, they're broken. I know, everybody went, oh wow, he's got 2 lumbar vertebrae. Everybody just knew that immediately. This person's in bad trouble. So their work. Alright, as vertebrae sits on top of each other. Do you see this area here? There is a notch. We're going to learn this when we do the bones. There is a notch created by the lower one, and there's a notch on the upper one. And there's a kind of a frame in there, a circle, right? So on each side of your spinal cord, that green is coming out of this. Right? If you hold it facing forward, it's coming out of each side. Well, that's a small area. So going through there, we have ascending sensory fibers and motor fibers. We have to have both of them. So what happens is all of the sensory is coming, and it gets onto, coaxially goes into the hole, and all of the motor coming out has to go through that hole. If you pictured taking the dorsal and ventral roots, and you wanted to get them through that hole, but they're kind of big, and you took them at that purple area, and you electrical tape them together for a second, just so they fit through the hole, that region is actually what's called the spinal nerve. Because as soon as it comes out of that hole, as soon as your taped area that you made to get through that area, as soon as it comes out towards this way, it's going to divide again into a, we'll get to that. But for representation purposes, these are spinal nerves. I'm just trying to explain how they get in and out of there. If you have problems with the spinal nerve, you'll see it's occurring at those frames. Okay? Now, once it leaves there, it will then immediately divide again into what's called an anterior and posterior ramus. Okay? Primary, that's fine. Dorsal ramus, ventral ramus. So I'll draw it on here what I was just saying. It's the opening between those 2 vertebral bodies called the intervertebral canal, or foramen, sorry, intervertebral foramen. That's where it's going to go through to get out of the spinal column. And so sensory came in, and motor came out. Now they're not really combining like fibers. They're just collectively coming together, like I said, taking them together to get through there. And so immediately outside of that, you can see that it's going to divide into a dorsal and primary ramus, which once again is on here. We're walking our way out, if you can't tell, from the spinal cord out. So when those divide, we're going to see some commonalities that as you divide, you're going to have a dorsal primary ramus and a ventral primary ramus on each side. So we want to know where those are going. Almost always, at all levels of the spinal cord, one of the generalities that we can say is the dorsal ramus is going to innervate the muscles of the back and the overlying skin. Actually, when we get to muscles and stuff, we're going to see that helps us in things that are close to the spine on the back or generally innervated directly by a spinal nerve named spinal nerve. And so the anterior root, though, is where we're going to spend a lot more time, because the anterior root is going on to serve structures in the body, upper, lower limbs, maybe the thoracic regions. Now at this point, when we're looking at the division of these posterior and dorsal roots, just keep in your mind that we're going to focus more on motor. We're talking motor fibers. We've already come back out. So really, oh, I won't say it. Okay. So we're getting further out. As we go a little further out on the spinal nerve, you also have what's called a meningeal branch. It innervates the meninges of the spinal cord. You also then have, here's a meningeal branch, and then you're going to have these communicating branches called rami communicantes, and you're going to have a ramus that leaves that ventral root, comes down, and another one that, one goes down, one goes back, out. I'm going to leave a lot of that for the sympathetic nervous system, but I'm going to give you a preview. Is when you look at a ventral root, the skeletons are in the way, so I've been neglecting y'all here. When you look at the ventral root, and it comes out, think of it, just simply think of it this way. We're talking motor, so everything that came out of here and went straight out was somatic skeletal muscle. Everything that is, if there is a lateral gray horn, we have autonomic output, right? S2 to S4, but T1 to L2. So if this is at T1 to L2, we have a lateral gray horn. At that area, we're also going to have an off-ramp and an on-ramp. And they call them Raymond communicantes. We're going to spend a lot. You don't have to get this just now. I'm just mentioning it now. This is a way for sympathetic autonomic fibers to reach this sympathetic ganglion. Right? I know I'm not being fair, standing over there, John. Like I said, this is just a preview that somatic skeletal muscle fibers go back out. The sympathetic fibers are going to go down and into what's called the sympathetic trunk. And we'll get to that. We will. I just mentioned it now so you kind of heard it, and then we'll see it later. One of the common things that we don't always realize is that, and it can be very confusing, is we form plexus. So in all regions of the spinal cord where spinal nerves come out, they're going to form a plexus, except the thoracic region. When a spinal nerve comes out, before they go to where they're trying to get to, they are going to join together with other spinal nerves. That's called a plexus. You can also use a plexus for a plexus of veins and things. So a plexus is formed by the anterior rami of the spinal nerve. Once it came out in the split, they have varying degrees, like they say, of complexity. A plexus also will contain motor and sensory. But what we're talking about, I know some of y'all have definitely heard of, is like the cervical plexus, the brachial plexus, thoracic does not have a plexus, sacral, coccygeal plexus. Hey, we'll say it again later, but you don't have to really think about is they're not doing a great job here. I just want to mention this first. The thoracic region does not have a plexus, which means that each spinal nerve that comes out of that level actually just runs right along the vertebra, or the rib. So T1 to T12, they just run right along the ribs. These spinal nerves, when they come out, don't combine. But in the cervical region, sacral, lumbar, they do. And they name this a plexus. And it can be a very confusing talk, but we're not going to get to that level. I'm only going to give you what you need to know. Is the roots come off of the spinal cord, they will join together, and depending upon the name plexus, it may be more, actually let's say it this way, the brachial plexus is a lot more detailed than other plexus. But one of the take-homes that I'm trying to get here, and the reason we're going to talk about it, well, I'll show you in a second. So depending upon the plexus, we can have different divisions. Most of them look the same, but the brachial plexus is different. So you have trunks that are formed by the roots come together, and the trunks are formed. And so you have a superior, middle, right, inferior trunk. That's associated mostly with brachial plexus. Then we have divisions as the trunks branch, anterior and posterior division, and then named nerves will leave the plexus. So once a nerve emerges from a plexus, it's often named for where it's going or what it's doing. And so each of the nerves can also have branches that come off of them that we could name. So if you're getting confused, let's go back here and look at the cervical plexus. So the cervical plexus job is to supply the skin, muscles, head, and neck, shoulders, the diaphragm. And what they mean when they say what all does it supply, they're saying what named nerves come off of the cervical plexus. All right, so if we look at C1, C2, and C3, we keep talking about they're going to go out and innervate things. Before they do that, fibers from C1 and C2 and C3 are going to combine together. They're going to get all mixed up. That's a plexus. That happens at all the different levels of the spinal cord, except the thoracic region. They'll mix up. And what we're going to concern ourselves with, I'm going to give you belay some real fears here right now, is it's like Krebs cycle stuff. I do not expect you to ever label one of these places in here. And I know a lot of anatomy classes do, but I want to focus more on musculoskeletal when we get there, what nerve went to there. Okay. And so we're only going to pay attention to the fact that that jumble happens and what it causes. You don't have to label this, but ultimately things are going to come off of the cervical plexus called a nerve, like the phrenic nerve, which I think it's important that we know what the phrenic nerve is. It innervates your diaphragm. So the phrenic nerve comes off of the cervical plexus. So you do not have to be able to name, I'm going to say it another way. I'm not going to ask you that way, though, and say, which of these nerves comes off of the cervical plexus? No, I'm more likely to ask you about the phrenic nerve and what it innervates. Right? So do not go and learn to diagram out these plexus for me, okay? Hope you're hearing that, because I'm not going to ask you, oh, you didn't know that the greater auricular is a branch off of the cervical plexus? I may mention that in some places, but if it's important, I'll tell you, hey, we need to know this nerve. You'll see what I mean, because I threw up a picture of this. Man, my watch is like, oh, they're off the conference. I can't stand group text. Cannot. I just now learned how to silence them, and I thought I was being cool. It silences all of your messages, though. I want to be able to wipe people out without them seeing what I'm doing. Put me in a group text. What was I saying? Oh. So there's the cervical plexus, but then when I do generally to tell you what I want you to know is I'll bring up a nerve that comes off of that and say, we're going to realize what this is going on to do. And the phrenic nerve is very important, and it's a great example of how the plexus affects things, because in working in spinal cord, I definitely saw this. If you look at, let's look at the phrenic nerve. Have you ever heard of C5 to stay alive? Yeah, you have. Most of you have. C5 to stay alive. Why? Because the phrenic nerve comes off of the cervical plexus. Well, in truth, that's a very true statement. You can go with that. In truth, though, the fibers that go into the phrenic nerve, if you look at it, come from C3. I cannot win for losing. We're going to have, we got any hackers? We need to hack into their systems. I think we could, whoever tried to come up and earlier tried to calibrate the pen. I've tried. You want to try, you can. I forget who asked me. But we need to hack the system first. All right. So C3 fibers, C4 fibers, and then C5 all go into what ultimately becomes the phrenic nerve. So if you sever above C5, they're saying C5 to stay alive because the phrenic nerve, you have a phrenic nerve on each side. You have two sides to your diaphragm. Your diaphragm is your main muscle of breathing, inspiration. You sever that, you're not going to be breathing, at least on one side, unless you get them both. But if you injure yourself above C5, it's likely you're going to lose the function of your diaphragm and die. But it's not just C5, because the question comes, well, you know, Mr. Wright, you ever seen anybody in spinal cord that had an injury like at C4 and they weren't on a ventilator? They're alive, but they're not, yeah. Were they on it when they got injured? Yeah. Do they sometimes use like CPAP and things like that at home at night? Yes. So just like in another area, if you sever, let's say at C4, you're going to have a shock to the body. And if you don't have resuscitation very quickly, you probably are going to die if you have a cervical injury at that level. You're going to need some respiratory assistance. But they have been able to wean people off of ventilators that are at C4. Why am I saying all that? That's the consequence of the cervical plexus. But always remember C5 to stay alive, because you don't want a C5 injury involved. Yeah?
Why would you say C2 is also part of it? You see, there's that branch where
Yeah.
I would almost compare it to like a lateral going down. Is that not it?
You could, but two answers there. One, just to be funny, oh no, it looks to me like it's traveling down. So C2 actually skips and C3 goes into here. But I only know that because they've mapped it. That's why I'm saying it that way, is they went in and said, let's stimulate the diaphragm and see which fibers, and they actually figured that out. So there are fibers, they know there are innervating fibers that come from C3, 4, and 5, but not from C2. It's just not represented well here, right? But I get you. Visually, it looks like it is. My anterior rami of thoracic nerve. I mentioned this a second ago. We do not have a plexus in the thoracic region. In that case, instead of the ventral roots, combining, they're going to just run out along the ribs. And we're going to change the name. So once a spinal nerve in the thoracic region goes out along the vertebrae, or the ribs, is now called an intercostal nerve. So your ribs are your costals. And so intercostal nerves are spinal nerve, ventral rami, that continue out along the ribs. But once they get out there and start doing that, they change the name to call it an intercostal nerve, between costals. So they're just not a plexus. So it's going to innervate all of the muscles that help you with breathing, the assisting muscles, the overlying skin, some of the abdominal muscles. The posterior rami of thoracic nerves, though, is like every other region. Remember, anytime you hear a posterior rami, it's going to go to the back muscles and overlying skin. Now here is the infamous brachial plexus. This is the one nobody ever, because every other plexus has roots and nerves. But the brachial plexus has, because of the extra divisions, the trunks that cause anterior division, posterior division, I'm still not going to have you define out and label the brachial plexus. Once again, we'll come back and talk about nerves that leave this area, but you don't have to learn this picture. But I need you to be familiar with it, and it may help you to look over it at least once, and maybe look at the mnemonic. You don't have to know the mnemonic for this test, but you will in a future class. You will study the brachial plexus is important, like upper extremity things. So I wanted to introduce it to you without having to make you diagram it out right now. But later, they're going to I know that other classes are going to talk to you, and people were saying they didn't realize years ago that the brachial plexus was different, that it had these divisions when they started talking about it initially again. And my argument is, you're probably not even going to remember it then. You will. You got a lot coming before then. So one of the things that comes off of the brachial plexus is the radial nerve. The radial nerve supplies the muscles, posterior aspect of the arm and the forearm. Remember, there's a big difference between arm and forearm. So the radial nerve is going to come all the way down the lateral posterior side of your arm and forearm. If you were to damage the radial nerve, like somebody stuck a needle in there and hit it, that wouldn't be very good. Or they put a cast on too tight, you can actually damage the radial nerve. Well, one of those areas that we get ahead of ourselves. If I look at anatomical position, and I say that the radial nerve comes down the posterior lateral side of the arm, and it goes into the forearm. These are all back here as extensor. Yes, sir.
Would this be like something you would look out for if you were doing like the subclavian line or anything like that?
Yeah, the brachial plexus is right there by it. All right, so hopefully you're not that deep, but it could happen.
Okay.
Yeah, certainly. And it's a good point. I mean, I like questions like that because then it kind of tells everybody, is we think about sometimes, when you said this, I thought, yeah, people don't always realize, like, oh, this procedure is no big deal. But we learn anatomy not only to make hard questions, no, I haven't said anything funny for the last hour. We learn anatomy in detail so that we know when we're doing a procedure that seems routine, what is next to that we may damage. You know, like, can you just go cutting into the jawline because you want to remove some type of lesion from somebody? No. We'll get to that later. We'll get to that in block 5, the guy who did that. Phase 2. All right. So if you're in an anatomical position, the radial nerve goes all the way down. These are extensors. These are extensors. So when we learn musculoskeletal, we'll learn that all the muscles in the posterior compartments of the arm and forearm are all innervated by the radial nerve. Radial nerve then, since it's innervating the extensors, helps to extend your wrist. If somebody has a cast applied too tight, they can actually have wrist drop. Where the wrist like that, you have, you lift it up and it drops. Because their extensor, the nerves, their extensors have been compressed or damaged, irritated. Just a little clinical correlation there. We got making our way down to the lumbar plexus. One slide on this. It goes to the abdominal wall, external genitals, part of the lower limbs. Because the sacral is also going to go into the lower limbs. But that is your lumbar plexus. And you have our sacral plexus that's going to go to the buttocks, the perineum, and the lower limbs also. Okay, so sacral and lumbar have a lot of overlap between them. The biggest thing that comes out of the sacral plexus, though, you have fibers from lumbosacral area and all the sacrum, and they all tie into this area here. That is called the sciatic nerve. Sciatic nerve, largest nerve in the body, but it's actually a bundle of two nerves together. You have a common fibular nerve, and you have the sciatic nerve, the tibial nerve. Sciatic nerve consists of the common fibular nerve and the tibial nerve. I don't think I say that on this slide, but when we discuss musculoskeletal, we will. Here I'm just giving you a clinical example of if somebody injures the sciatic nerve, you're going to have symptoms of that, which is pain extending down the buttock, down the posterior lateral aspect of the leg, into the foot. Generally, getting down into the foot is a good, sure sign that it has something to do with your sciatic. If it's up higher, there's other nerves that can cause that. Like, or maybe you didn't damage the sciatic nerve, maybe your piriformis is tight. You ever heard of piriformis syndrome? A lot of y'all probably developed it within this year that you're sitting here. Piriformis gets tight, stretch that thing out, and it'll be good. I got to put a plug in here, is when you look at a chart, you should never write that the patient's diagnosis is sciatica. That's not the diagnosis. Sciatica is a symptom. Sciatica is your injury to the sciatic nerve results in sciatica. Sciatica is a group of symptoms of I got pain down the posterior lateral aspect of my buttock, down to my leg, to my foot. You don't write, but you'll see it all the time when people write diagnosis, back pain, no injury, and all this, and they'll put the diagnosis as sciatica. Now, you may not know the diagnosis, but you got to get a differential going because what I'm making a point of here is you need to know what's causing the sciatica. So a pinched nerve could cause sciatica. It's my attempt to fix that whole, putting that as a diagnosis. And so herniated disc, pressure from the uterus. anything that puts pressure on that sciatic nerve. Improperly administered gluteal intramuscular injection, that would be great. Better watch out for an elbow. You hit the sciatic nerve while you're doing that, that would be. I mean, I'm definitely not coming back. All right. Cutaneous, and we're getting on a little bit of less heavy stuff. Less heavy stuff. Cutaneous sensations. So those are tactile sensations, touch, vibration, itch, tickle, heat, cold. But we can map all these. We can map them in two different ways. 90% of the time, the rest of your time is practicing. You'll know dermatomes, or you'll look at the dermatome chart. But we're in class, but there are actually dermatomes, and then there are peripheral nerve fields that come off of cutaneous nerves. There is a difference between saying a dermatome and a cutaneous nerve field, or peripheral nerve field, because the plexus mixes things up. So we'll spend a little bit of time. We'll slow down here for a second and say a dermatome, by definition, is the area of skin that provides sensory input to the CNS via one pair of spinal nerves or cranial nerve 5. Right? We have to throw cranial nerve 5 in there, remember, because everybody's walking around with the big Roman numeral 5 on their face, because that does sensation for the face. So when we say dermatome, we'll say like the T4 dermatome is an area of skin where all of the cutaneous sensation in that area goes into the spinal cord at the T4 level. Now, I only want you, I know some of y'all hate the stepwise process. We're going to learn this dermatome chart in musculoskeletal because I do it in a regional approach. So when we study the dermatome chart, like knowing which one's T2, T3, T4, and there are different versions of the dermatome chart. You just gotta, they're pretty similar, but depends on how you look at them. But you gotta stick with one. They're generally close. Here's the thing. I don't want you to be able to label a dermatome just yet. I just want you to know what understand what a dermatome is at this point. When we get to musculoskeletal, like the thoracic region, we will learn the thoracic region dermatomes. When we get to the lower extremity, upper extremity, we'll learn those dermatomes there individually. So you don't have to memorize this picture just yet. But I'm going to show you how to figure out this picture later by just using landmarks. All right, so if we go back to what I was saying, we go to T4. And there's a little offset at the midline of the body too, sagittal line. But that's T4. So if you were to touch the skin at the T4 region, which is at the nipple line, if you were to do sharp dull or something in this area, whatever sensation receptor picks that up, that is going to enter the spinal cord at T4. That's the definition of a dermatome. So we can map those. That's how I know that my patient is getting worse or something in spinal cord, because they used to be able to feel at one dermatome, and now they can't feel there. So these are strips of skin. So if you look at anywhere on this dermatome chart, and you pick out and say, well, the T10 region at your belly button, well, all of that area of skin, that sensation when it travels to the CNS is going to enter the T10 spinal nerve level at T10. That's a dermatome. That's easy to understand, harder to conceptualize when you compare it to a peripheral nerve. So I need you to keep this in mind. The plexus can make a difference. All right, so on the left here, we have spinal nerves that are dermatomes. So they're just general in numbers. So let's say one here comes out to this area of the skin, and dermatomes tend to overlap. And so here's your, let's say, T2 dermatome, and then you have T3. That's fairly clear. One area of skin, it goes in. But remember, we can map that and it's true, but we also have the plexus. So plexus comes in and they combine. And they form this peripheral nerve, like the radial nerve. Right? Nerves come out of the plexus. When a branched nerve goes out, it's going to, like the radial nerve doesn't just innervate the muscles of extension like we talked about. It's also going to provide branches out to the skin for cutaneous sensation. Because of that, because those branches come off of that radial nerve out there, and there was a plexus between the spinal cord and that area, that means that you're going to have a region out here called a peripheral nerve field. I will explain this a lot more in musculoskeletal, but if there's a chart and you can look, and if you were to say, like, pick an area of dermatomes, like up here there's C7, C8, up in your upper extremities. Well, what if I didn't have any other loss of dermatomes, but over here I had like a circled area where I lost sensation, and it encompassed several dermatomes in that area, but nothing above or below that. That's due to the fact that peripheral nerves are going to those areas of skin. They're traveling back towards different plexus on different nerves. Does that make sense? No, it doesn't.
So the thoracic region is more linear because it doesn't have a plexus. Is that why? If I'm just looking at it, so the left picture, bottom left, that's like an example of the thoracic region, right? Because it doesn't have those plexuses.
But I can't say yes to that. I mean, and you're thinking right. This makes sense, like you picture a nerve going out along a rib, right? But all the areas do that. But even in the thoracic region, right, I could lose an area, like a large area of skin, where I've lost sensation around that area, and it encompasses multiple dermatomes. But I didn't really lose anything above or below that. That's a peripheral nerve field, and that's caused by the nerves that are innervating that area being jumbled up at the plexus. What matters is this. But in the thoracic, that's why you're really correct. In the thoracic, you're not going to have a plexus. Yeah.
Wouldn't the dermatomes be, so if the picture depicted his hands this way, wouldn't it be kind of more linear too?
Yeah. I mean, but they always put an anatomical position. As you're saying that. So it looked more like the thoracic region.
Right.
The problem too is there are differences, like anterior and posterior dermatomes look a little different. I don't know why they don't put them out like that. They like to do everything down in PowerPoint.
So, what you're trying to say is, say if there's an injury on the spinal nerve on the right side here, at like 2, whatever one that one is, it's going to affect 1 through 3 of those dermatomes.
It can, yeah.
It can, and that's why it's a broader spectrum of affection, you know. And so you could say, hey, this area is involved, area 1 through 3. It could be either an injury or something going on with the root at 1, 2, or 3, or all of them.
What you're getting at is if I come out here and I took a scalpel and there's no plexus here, and I came out, same thing you're saying, I think, and I was to sever this person, I would lose this dermatome, right? Or if I severed more than one. But what if, let's use this one, see if this confuses you or not. If I came out here and let's say here's that same level coming in, and I cut it here, I would lose the dermatome. But if I cut it here, I would lose a different area than just that dermatome, because these branches go everywhere after that. They go to larger areas. They don't just go to that one area of skin. So the plexus, because they combine, makes a big difference in where those nerves came from. That makes sense? Yeah, maybe. You know, everybody's looking at me like, why are we spending so much time on this? You'll see in musculoskeletal. They come up in we will need to know peripheral and dermatomes in musculoskeletal. For now, I just want you to understand what a dermatome is really. All right, we'll finish out almost talking about shingles. Okay. We'll do 3 more real quick, because we already talked about the other 2. Shingles is interesting because it's an infection of the peripheral nerve system caused by herpes zoster. So the virus that causes chicken pox stays in you forever once you get it. Right? Once you have chicken pox, right, that virus, varicella, is scared. Chicken, matter of fact. And it goes and it hides in the posterior root ganglion, on your sensory nerve root ganglion there. And if you become immunocompromised, stressed, around here, we often see shingles come up during PA school because of people being so stressed at times. At least when I was there, we had several. Because stress or breaking down the immune system or just aging itself can cause a reactivation of herpes zoster, and that's called shingles. And shingles is still herpes zoster, but shingles will cause pain, discoloration, and blisters. And level of pain depends on the individual. It's not pleasant, but it will follow a dermatome pattern because it's living in the posterior root of that dermatome. Is it at more than one level? Yeah. But it gets activated like in one, and generally it's thoracic. You'll see a lot of that. So you'll see a strip on one side, generally not even both sides. You know, it could be maybe a strip of dermatome, right? Or it'd be on their face, that kind of thing. I actually had shingles once when I shouldn't have, and they were puzzled. And it came down though, and it took out my ophthalmic branch, going back to cranial nerves, and went straight into the nerve, basically the eye. And I had what they call herpes zoster ophthalmicus, a reactivation of that old chickenpox when I was a kid. And it you couldn't tell, but I can't really tell anymore, but it scarred like part of my cornea there from it. It was crazy. They thought I was crazy for a while. Anyway, that's all we got time for today. You can decide whether or not you want your kids to get the varicella vaccine. I'm not an anti-vaxxer. I wish I hadn't given it to them, because after I've given it to most of them, I realized the vaccines don't last forever. Because I'm trying to calculate, when I was deploying to Afghanistan, we're at Fort Riley, they took us all in, and we're giving shots, and said, hey, everybody's going to get smallpox. And I'm like showing my scar, and I'm old enough to have a scar from smallpox vaccine, and they're like, well, everybody's getting it. I'm like, I'm talking to this doctor, I'm like, why would I need a smallpox vaccine? It's good forever. And they're like, no, studies have shown that it's not good forever. And I said, then why, I'm going to leave you with this, why are we giving people the varicella vaccine if it's not going to last forever? Because if you get chickenpox, this is just Wright's reasoning, I'm off the podium. If you get chickenpox as a kid, you're probably going to live. You get chickenpox as an adult, that's pretty serious. So I don't want to get it after the vaccine went in. Don't go off thinking I'm anti-vaxxer. My kids have all their vaccines except one. All right, y'all have a good day.